Hello and welcome. Today we're diving deep into a complex and often overlooked lung condition, metastatic pulmonary calcification, or MPC. We'll explore its causes, how it affects the lungs, and what can be done to manage it. Let's unravel the mysteries of MPC together. So, what causes metastatic pulmonary calcification? The primary culprit is an imbalance in calcium and phosphate levels in the body. Conditions that lead to hypercalcemia, which is elevated calcium in the blood, are major drivers. This includes chronic kidney disease, especially in patients on dialysis, hyperparathyroidism, where the parathyroid glands produce too much parathyroid hormone, bone tumors that release calcium, excessive vitamin D intake, and even certain medications. Essentially, anything that floods the bloodstream with excessive calcium can potentially lead to calcium deposits in the lungs. Let's talk about the pathophysiology, or how MPC actually develops. When calcium levels are high in the blood, this excess calcium begins to deposit in various tissues, including the lungs. Now, why the lungs? The lungs have a relatively high oxygen tension and alkaline environment. These conditions favor calcium phosphate precipitation. The calcium binds with phosphate, forming insoluble calcium phosphate crystals. These crystals then deposit in the pulmonary interstitium and alveolar walls, the delicate structures of the lungs responsible for gas exchange. Over time, these deposits harden, causing inflammation, fibrosis, and ultimately impairing lung function. It's a slow and progressive process that gradually compromises the ability of the lungs to effectively oxygenate the blood. Epidemiologically, MPC is considered relatively rare. It's more commonly observed in patients with chronic kidney disease, particularly those undergoing hemodialysis. Studies suggest that a significant percentage of dialysis patients may exhibit some degree of pulmonary calcification, although not all of these cases will be clinically significant or symptomatic. Other predisposing conditions like hyperparathyroidism or malignancy-related hypercalcemia contribute, but to a lesser extent. Unfortunately, precise prevalence and incidence rates are difficult to ascertain due to the often asymptomatic nature of early MPC and the lack of widespread screening. The signs and symptoms of MPC can be quite variable, and in the early stages, many individuals experience no symptoms at all. As the calcification progresses, symptoms may begin to emerge. These can include shortness of breath, particularly with exertion, a persistent cough, chest pain or discomfort, and in more severe cases, even hemoptysis, which is coughing up blood. It's important to remember that these symptoms are not specific to MPC and can be caused by other lung conditions, making diagnosis a challenge. However, in the context of known risk factors like kidney disease or hyperparathyroidism, these symptoms should raise suspicion for MPC. Diagnosing MPC typically involves a combination of imaging and clinical evaluation. A chest X-ray may reveal increased density in the lungs, but it's often not sensitive enough to detect early or subtle calcifications. A high-resolution computed tomography, or HCT scan, is much more effective. It can visualize the calcifications as small, dense nodules or plaques throughout the lung tissue. In some cases, a lung biopsy may be necessary to confirm the diagnosis and rule out other conditions. Blood tests to assess calcium, phosphate, and parathyroid hormone levels are also crucial to identify the underlying cause of the calcification. While there aren't distinct types or classifications of MPC in the traditional sense, the severity of the condition is often categorized based on the extent of calcification and its impact on lung function. Some individuals may have only mild, asymptomatic calcification detected incidentally on imaging, while others may experience extensive calcification leading to significant respiratory impairment. The clinical course and management strategies will vary depending on the severity of the disease and the underlying cause. Treatment and management of MPC primarily focus on addressing the underlying cause of the hypercalcemia. For example, in patients with chronic kidney disease, this may involve adjusting dialysis regimens, using phosphate binders to lower phosphate levels, and carefully managing vitamin D supplementation. In cases of hyperparathyroidism, surgery to remove the overactive parathyroid glands may be necessary. If malignancy is the culprit, treating the underlying cancer is paramount. There are no specific medications to directly remove calcium deposits from the lungs. However, supportive care, such as oxygen therapy and pulmonary rehabilitation, can help to manage symptoms and improve quality of life. Corticosteroids may be considered in cases with significant inflammation, but their use is controversial and needs careful consideration of risks and benefits. Preventing MPC relies on proactively managing conditions that lead to hypercalcemia. For individuals with chronic kidney disease, adhering to dialysis recommendations, maintaining a balanced diet, and avoiding excessive vitamin D or calcium supplements are crucial. Regular monitoring of calcium and phosphate levels is also essential. For those at risk of hyperparathyroidism, early detection and treatment are important. By addressing these underlying risk factors, we can potentially reduce the likelihood of developing MPC. The prognosis for individuals with MPC is highly variable and depends largely on the severity of the calcification, the underlying cause, and the overall health of the patient. In mild cases, the calcification may remain stable and asymptomatic for many years. However, in more severe cases, MPC can lead to progressive respiratory impairment, decreased quality of life, and increased mortality. Recent research efforts are focused on understanding the mechanisms driving pulmonary calcification and identifying potential therapeutic targets. Some studies are exploring the use of bisphosphonates, which are medications used to treat osteoporosis, to inhibit calcium deposition. Other research is investigating the role of inflammation in MPC and potential anti-inflammatory therapies. While these approaches are still in the early stages of development, they offer hope for more effective treatments in the future.